So welcome, those of you that aren't in COM, to our colloquium series. Just a preview that next month on March 13th, that's a Wednesday, we'll be having Yaroslav, oh my gosh, his last name starts with an S. Does anyone remember? All right, he's going to be presenting on Cold War video game development in Yugoslavia, so it should be really interesting. So that's on our radar. Slavich, I believe his last name is. My tongue. But for today, welcome, those of you that are visiting from outside of COM. Today's guest is Ashley Duggan. She is an associate professor in the Department of Communication Department at Boston College. And she studies interpersonal communication and health, as you'll hear more about today. And although she's been at Boston College for some years now, and has been working on a lot of different projects, she's making a transition into now being the head of the Institute for Communication and Family Medicine, which we'll hear a little bit about.
You love her.
So I'll let her speak to that. So that's exciting and new, and is working more with practitioners. So that should be really interesting. So she'll speak for an hour-ish, and then we'll have Q&A. We are filming, just to give you a heads up. But with that, I'd like to welcome Ashley Duggan.
Thank you. Thank you so very much. It is such a pleasure to be here on so many levels, not the least of which is that what you're getting is like the first iteration of what is sort of a book talk that came really from Seattle when ICA was here with a meeting with the series that's co-sponsored with IRR and Cambridge Press. And the title of it is Health and Illness in Close Relationships, and it's somewhere like being mailed from Cambridge Press along the way. And then the other thing that just, I'm not sure, this is the first time I've done this and I'll have to play with it. One of my new aging answers to life is glasses, not just one, but two pairs in one of those doctor's appointments where you get reading glasses and distance glasses. So which is this? And you also get sent to whether you're allergic to seafood, which is my favorite food, and get told you've gained 10 pounds, all in the context of one healthcare interaction. That being a tiny little glimpse of we live with this in everyday life. When people learn that this is my research area, one of the things that I always hear are stories that are tiny little glimpses of things in life that are always inherently vulnerable and complicated. In some small ways, like we learn how to play with the glasses, and some big ways, like we have all kinds of conversations that can't ever even be had. With our aging society and our ability to better diagnose and our ability to better treat and our ability to manage symptoms, we all have stories of ourselves and stories that are really of people very close to us. And I'll start with a glimpse of two of mine who've been really important in my life. One is the story of Tim Edgar, who was really close to Mara Edelman, and I've heard all kinds of Mara Edelman stories, but never actually met her. Tim Edgar is seen here with Leslie Schneider, who's also in COM at UConn, and this is when the three of us traveled to Ethiopia for this global health conference. 9 years ago, or about somewhere then, we sat in this lecture together, and one of the topics was predictors of life length. And then when we got home, there was this online calculator that Tim did, and he said, so there's something I actually need to talk to you about. He's like, my online calculator said that I had 4 more years to live. And he's like, so my parents both died unpredictable or somewhat unpredictable and somewhat unexplainable deaths in their mid-50s, and I'm kind of approaching mid-50. And so at that point, he went home and he's like, I want to do things differently. And he lost 45 pounds, and he adopted a series of healthier life choices. He kept the weight off, he kept his ultimate, his other kinds of things until he died this untimely death in his 50s. At his memorial, there were several people, and they offered different kinds of glimpses of Tim's life. And one of the introductions was that you would learn things at his memorial. You would learn parts of his life. Even if you felt like you knew him well, you might learn different parts of his life that you only knew one part well. And Health and Illness illustrates some of those complexities. Another is a story about my mom, a little glimpse of those. My mom was diagnosed with Parkinson's 10 years ago. Having a body that's defined by limits with a fully functional mind has always been one of her greatest fears. She loves the beach, but one of the side effects of her medications is that she has to completely and totally avoid the sun. She's discussed for years and years in great length and with great clarity her hopes of not ever going through life with ongoing chronic care. And I can remember those conversations from as many years as I can remember. Those hopes made sense until they met the competing realities of decisions that actually don't fit the symptoms. People don't actually really know that she has Parkinson's. She still goes to yoga 5 days a week. She avoids situations that are difficult, like walking any distance or going out at night. She has a particularly hard time opening containers, but even my stepfather wouldn't know that, because one of the things that's really important to her in life is to still be able to prepare dinner every night. So I'm not actually sure how, when I'm not there, she gets the tape off of a box or pulls the tab on a package, because those seem nearly impossible when I'm there. But she thinks of herself as really a nurturer, and this is an important part of her close relationships in the Southern lady and the many roles that she takes on, that food is always ready. The World Health Organization defines health, but their charter implies much more breadth. In language that's indicative of a far broader experience, a biomedical orientation is far more consistent with the language of disease as a disorder of the structure or function in specific symptoms. This broader experience of malady of disorder is far more consistent with our language of what we would say illness, which really defines a host of social experiences and a social construction in the context of some kind of malady. Defining health and illness might at first seem as quick and as simple as having or not having a diagnosis, but really understanding health and illness quickly becomes a really ambiguous and complex goal with interconnected considerations of science, of technology, of philosophy, of core values, of communicative inactions of all kinds of situations, of psychology, and of competing stakeholders even in our very closest relationships. Defining health and illness then requires acknowledging the context of culture, of economic conditions, of questions that can't ever be disentangled from all kinds of core values of marginalization. Complete mental and social well-being, then, is far more reaching and calls on additional political and economic domains that require some kind of really innovative and imaginative considerations of far broader constructs than the diagnosis and management of disease. As a starting place, I'm sharing a picture of one of my freshmen. I call her my precious freshman, when she wins the national championship with the second friend of hers who's coming in second place in the national championship in track and field. The WHO definition is broad and ambitious, really broad and ambitious. It's a definition that we might not actually, any of us, qualify as fully healthy. It's a definition that we might envision as this version of what is healthy. The writers of the World Health Organization Constitution defined health as first dependent on the presence or absence of disease, and then something that we have as a really ambitious. Instead of giving more tight definitions, it's defined then as a state of being, but then misses a kind of trajectory, a kind of process, the interplay between the biological and the non-biological, the aging population, the years we might already have of living with a chronic diagnosis as the norm, and the inter-individual variability in health processes. Consider disability as one of the challenges and strengths of what it means to actually live with an ongoing illness in a close relationship. How disability misses the coexisting components. How living with disability we might think of as people having some abnormality that might be measured as symptoms of disease as measured ill, but are these people actually ill? Are people who feel well, but who others define as ill, are they ill? Do they function well, but do their biomedical markers indicate some kind of abnormality, and is that what makes them well? People can find ways to live really productively for many years following a diagnosis. when people are living significantly longer, because technology enables more sophisticated diagnosis, because pharmaceutical advances allow for treating far many more medical conditions, people can live for decades and often do with a chronic disease or disability. The WHO definition suggests some kind of definitive illness diagnosis for people who have a chronic disease and or a disability. What about instead recognizing the capacity for people to accept chronic illness or to accept disability as a natural part of the human condition, including within our close relationships? When we work with the disability advocacy community, one thing that we look at is the language that people use for disability, where we have an opportunity to see the social response to disability as the problem instead of the individual limitations. We might think of physical health as first diagnosed as biomedical. A complete state of physical health is really difficult and perhaps impossible to achieve. Perhaps we're just one scan away from whatever the diagnosis is. Viewing health with an absoluteness of the word complete poses an ongoing emphasis on potential screening for conditions not yet diagnosed. Complicated medical screening, in addition to our ongoing screening of our own biomedical markers. One thing I like about this image is that this is an organization, a nonprofit that's just, it's called Recycle Health, and what it does is it gives your Fitbits and your own biomedical markers to people in the Boston area who are under-resourced. Individuals declared healthy today might actually be diagnosed with disease tomorrow, and medical professionals are really trained and positioned to recognize this biomedical piece and to diagnose disease or malady. The broader concept of health and illness quickly becomes evasive and is really missed by everything we know about the definition as fits the World Health Organization definition. If you consider the environment as context, then inequalities and social disparities are also illustrated in all kinds of questions about pollution and the environment. Consider all of the public health considerations of the many places that we see inequalities. Pollution is just one of the places that it's visible, but not yet even included in what we measure. Public health is grounded on the premise that adaptation and self-management are important, but within the context that health is also a fundamental human right protected by entitlements, and it's also a resource for life that's shaped by social, political, economic, and environmental factors. These core factors are outlined in reading the WHO principles, but less frequently included in the shorter definitional excerpts. Public health emphasizes population-based health and works on the premise that changes to the social, political, economic, and environmental factors translate into greater health gains than any individual action. When we talk about relationship-centered processes in healthcare, it's become a way that we're reconceptualizing healthcare, which actually misses really all of the relational constructs as they exist in the relationship literature. Relationship processes in healthcare delivery, and this one comes from the Cleveland Clinic, and it's a video that's about empathy, and then it gets you into all kinds of things that if you do work on relationships, you see that it's actually complicated in even understanding what is empathy, other than putting yourself in somebody else's place. Health and illness concepts are inherently tied to models of delivery in which the symptoms or illness symptoms, on the contrary, are diagnosed and treated. The conceptualization of healthcare and medicine to this relationship-centered model adds into the kinds of scripts that we ask your experiences with other people in your close healthcare system, and has the healthcare provider consider patients' experiences in relationship-centered ideas like emotions and other kinds of things that are connected to broader definitions of health, but it certainly is not a reciprocal kind of place that we think of in close relationship processes. So let's look next at what do we mean by close relationship processes and how are they inherently connected to health and illness. So we'll go through some of these aspects first of what are close relationship processes. Close relationships and illness. Consider depression as an example. I constantly tried to let go of resentments over his poor control and his constant denigration and despair. I could feel his depression. We couldn't live together, but we couldn't live apart either. It was really worse when people would tell me that he's mentally ill and what I should do is leave him. You wouldn't tell a person whose husband had cancer to leave him. We didn't have good answers, but I knew that we were a couple. I tried to let him go, but I knew it just wasn't right. I couldn't be there for him, but I couldn't be without him either. I could hear it in his voice when he was in trouble. I internalized how to handle the reality for him, how to avoid arguments, how to acknowledge his feelings without getting caught up. I said loving things about how much I cared for him, but sometimes it was just too much for me to take. As this little illustration lets us see, including the couple with one depressed individual, close relationships shift the understanding of illness, and illness shifts the understanding of our close relationships. When we're committed to a close relationship, sometimes we work through things that we didn't envision. Sometimes we realize we were less committed than we ever might have considered. When we conceptualize relationship science, childhood friends, school friends, neighborhood friends, college friends, work friends, best friends, boyfriends, girlfriends, the fundamental construct underlying that is some aspect of closeness. When people describe what makes life meaningful and they talk about their happiness and what they most value, people often identify close relationships. Close relationships, in what we understand and in the literature, are vital to well-being, including happiness, mental health, physical health, and longevity. On the other hand, close relationships can also challenge everything that we thought we knew about our own well-being, about our own emotions, and about mental health in ourselves and in our close relationships. Close relationships have some kind of holistic quality, that relationships are unique in the kinds of ways that we are connected, and that they're more than a set of interactive moments and more than any other complex set of variables. Close relationships can bring out the best in us. Close relationships can also be manifest in really complicated dilemmas and contradictions and paradoxical patterns where we sometimes enact and encourage the very behaviors that we thought we wished to control. I've tried to actually choose pictures every time that are not just like only the warm side. I've tried to have you see the complexity of turbulence as is manifest in all of these pictures. When my students were helping me put them together, they kept finding these versions, and I'm like, well, it's really nice you see that as the version of a 40-year marriage, but actually I want turbulence in every one of the pictures, and you can just call it the dark side if you need to. Close relationships connect to this really vulnerable part of our lives, to our greatest joys, and also to our really deepest disappointments. Colloquial definitions of close relationships capture the joys, the heartaches associated with intimacy and vulnerability. Perhaps songwriters, poets, novelists, theologians, and philosophers have long acknowledged the centrality of relationships to human existence. People sometimes describe their romantic partner or their close friends as a part of me, as attached to the hip, as soul sisters, as the family we choose. And on the contrast, anyone who's also felt the poignancy of deep loneliness can describe the desire for meaningful relationships as something that is of a deep longing. A relationship functions on the specific qualities of each person and the unique interaction patterns within this particular relationship. This one is from Caringbridge. This is one of my college roommates. They have a baby. They had just finished posting all these pictures of her being surprised that they were having a third child, and then they're sharing his Caringbridge plan of attack. Some indication of reciprocity in the feelings or behavior is necessary in order to develop and maintain a close relationship. Closeness with another person can never be done alone. Closeness also involves that both people have to understand the closeness. I love you, but I don't want you in my life. That kind of ambivalence isn't consistent with what we think of as the closeness. Although some degree of ambivalence exists in close relationships, a high degree of ambivalence by either person does not translate well into closeness over time. And sometimes the vulnerabilities of health and illness can translate into that heightened ambivalence. When we think of emotional bonds are not just positive emotional bonds, but they're also negative emotional connections. in close relationships, people experience really strong emotions, strong positive emotions and strong negative emotions. Within close relationships, people experience the mildest ranges of contentment, annoyance, and anxiety to the most profound experiences, maybe more than we could have ever imagined, of love, rage, and despair. With serious diagnosis, emotions can be intensified and complicated by the ongoing demands of treatment. Among varieties of love associated with close relationships, friendship and compassionate love particularly connect to the self-sacrifice that can be manifest during the ongoing illness trajectory. Dimensions of respect might be observed in curiosity, attention, empowerment, and reciprocal and validating dialogue. Emotions might also be suppressed over the course of illness. Although sacrifice can be good in relationships, not all sacrifices are equal. Some sacrifices, including some sacrifices connected to health and illness, have some kind of feelings of joy, and others leave lingering feelings of frustration or resentment that distract from the relationship quality over time. Some of the things that happen in illness can perpetuate the insecurities that already existed in relationships. One of the consequences of understanding how dyadic messages contribute is that sometimes expressing something that we are insecure about can translate into this feeling of walking on eggshells, so it's something that we need to avoid. And the complications of the hardness of making choices around diagnosis, the doubts about the relationship, the doubts that might have already been there before the diagnosis, the ongoing pessimistic interpretation of the feelings, the not being on the same page about the pessimistic interpretation of the feelings with a diagnosis, or just how long we have to keep renegotiating our own responses and feelings about the diagnosis, can have these kinds of qualities for both the individual and the partner. So there is a dark side of close relationships. Communication has this paradoxical sense, sometimes even in everyday health kinds of behaviors, like we see it in the research about weight, about eating, about drinking, about drug use. We see it perhaps most poignantly in substance abuse treatment with this poignant example of communication in the family system as connected to substance abuse treatment, where we see these relational facts that have some kind of reciprocal effect of the ongoingness of the things that I'm doing in the relationship that might actually be more hurtful than helpful over time. If we think about the attributes of health and illness context for close relationship context, what we've done is flip the lens of what we see in the health literature on trying to bring in relationship processes into something that's actually already a tightly scripted context. Lots of attributes of health and illness for the close relationship context. Health and illness shift the everyday context, and they shift our everyday explanations for what our close relationships are. They shift the processes by which people diagnosed with a serious illness might be fine at some times and not fine at other times in conceptualizing, in thinking, and in talking about life events. People approach life as if we go through life with some kind of predictability about what will happen. One really important part of a serious diagnosis is that it changes that assumption and instead makes us see differently, sometimes forces us to wrestle with, and sometimes makes us back away from the fragility of recognizing those choices and as not necessarily linear. Researchers who approach development and testing of theory as if we can account for these kinds of connections. What we know about health and illness in close relationships is that these unfolding vulnerabilities very rarely can actually be predicted. Instead, the trauma or the disaster of the serious illness shifts our core in an instant in that image. Something changed in a very moment, where everything that we thought we knew about ourselves instead is shifted on these foundational assumptions of the very explanatory frameworks we thought we'd lived with. Attributes for the health and illness context then shape and shift the relational processes as the relational processes shift the ongoing assumptions that we make about the health and illness. Instead, it becomes this demanding taskmaster, so to speak, so that illness diagnosis shifts roles, shifts relationship choices, and shifts relational assumptions. In challenging assumptions, one of the things about fragmented uncertainty, it's not just a kind of uncertainty or multiple kinds of uncertainty, and we're not just trying to reduce uncertainty, but we face these ongoing fragments of certainty, almost like we face ongoing fragments, as we see in people dealing with complicated grief. Fragmented uncertainty at many turning points, and in sometimes invisible and increasingly visible or invisible in our close relationships aspects of illness, and these pose ongoing complications for coping. Romantic partners might shift from passionate to compassionate love. Social support functions might shift from nonlinear needs and ongoing renegotiation as new issues continue to arise. Choices about disclosure shift with the changing needs, sometimes in response to stigmatized choices or things that come out in the vulnerabilities that we otherwise didn't need to share in our relationships. Couples drift from moment to moment, sometimes embracing, sometimes accusing. Sometimes people count on the illusion of control while ignoring the ubiquity of chaos, the better to chart lives with a sense of continuity and security. We might feel like we have it all figured out. When to buy our first house, when the baby will arrive, when the second baby will arrive. We plan on satisfying careers. We plan on traveling, growing old with dignity, and retiring with some kind of security in our income. Instead, some of us separate or divorce, some of us endure really boring jobs and wind up with cats instead of kids. But that's not the script that we write for ourselves. And never in the story is there a placeholder for the intrusion of illness. Sudden trauma or a terrible diagnosis slams into us like we think of an image of a stray bullet. It penetrates our core in an instant, in the space between two breaths. It can fade our dreams. It can change these idealized image of our partner and take them off the pedestals and instead immerse us in the reality of our own fragility. The patient is actually not the only causality. Illness also attacks our belief in the future and our promise of what we thought love was. When illness strikes, it becomes the hub around which the new life revolves, around which activities are tethered, around which our sense of time is changed. It determines how far we can go from home, whether we can contribute to work, whether we can eat the foods that we enjoy, whether and how we can be intimate with our lovers. When our partner becomes patient, as if wearing a carnival mask, the once familiar face can become a somber profile of disease. It can be this demanding taskmaster. As the exhaustion continues with the ongoing pieces, resentment can also replace compassion, and passion and humor can vanish. Sometimes it's impossible to come out of this dark humor by separating the ideal image from the new body. In the changing expectations, we sometimes find a new normal, and then another new normal, and then another new normal. Medical changes, financial changes, logistical constraints all require this kind of immediate attention, and close relationships can be the unforeseen aspect of what is lost in illness or injury. We cannot remake the foundation as it was before the illness. The health crisis requires a recalibration of close relationships, which assumes then that the close relationships can go through the recalibration. Health and illness considerations shape relational processes, and they requires that we shift to diagnosis and think of the ongoing progression as a trajectory. Finding and accepting some kind of new normal shifts the roles, shifts the expectations. The body might shift from healthy to sick in a short amount of time. Close friends who'd been connected socially before might learn to administer medications. The new normal might be so drastically different from what we'd hoped. The new normal might not feel so normal at all. When people cannot do things for themselves, they might depend on others. We sometimes depend on other people that aren't our very closest people because they're the ones that can do it with us. You might imagine that this is like a comfortable space in mind, that I regularly sit with people in treatment, right? I organize who is comfortable with these treatments and being able to adapt to things that we can fill in, that we become, close in for that amount of time. Which also illustrates, again, the inequalities of how relationship supports are also manifest. So it's not just the inequalities in the diagnosis and management, it's also the inequalities in how relationships can buffer, or relationships can actually exacerbate all of these challenges with health and illness outcomes. Although we have plenty of evidence for relationships, for social networks, and for communal coping as connected to better outcomes, relationships can actually buffer, or they can exacerbate health and illness outcomes. And then we're going to go through 2 examples of how that actually looks, and how. And the 2 examples we're going to look at are type 2 diabetes and physical disability, because they give a brief glimpse into the complexity of health and illness as interconnected with the broader context of relationships, which co-occur with these extensive considerations of social level networks and also societal level attributions, and things that are inherently also connected to bias. Type 2 diabetes might be interpreted as shame or blame, the idea that people developing the diabetes then have knowingly make bad or maladaptive choice in us. And I'm intentionally using these languages that are labeling because of the places that our mind goes in the language of labeling. I'm hoping that you're sensitive to that language and labeling. We also then might see that diabetes is a social and environmental problem as a crisis around neighborhoods loaded with fast food chains, liquor stores, and billboards advertising junk food and limited incomes. Public discourse around disability at worst focuses on deviance and dependence. In some of our studies, one of the things we have is they come in with their partner, and inevitably, in like more than 90, I won't say all of them, in more than 90% of the interactions, the doctor over and over recurs to who's your caretaker, as opposed to your being the caretaker for the child, or your being able to take a role other than dependency. If you're not familiar with it already, one of the places you might look at for looking at diabetes as embedded within social structures is the Bigger Picture campaign. Are you familiar with that? Out of California. They take the idea that type 2 diabetes used to be known as adult onset diabetes, and that diabetes is now a disease that begins in childhood, and the prevalence of diabetes in the United States has doubled in the last decade, particularly among Black children, and tripled among American Indian children. Black and Hispanic children have 8 times the risk of developing the disease compared to others. Faced with these numbers, then, public health experts and art educators have created this really interesting and novel approach that I'll be surprised if some of you aren't teaching in your classes by this time next year, that brings agency to teenagers in really doing some kind of slam poetry and giving voice and agency to diabetes as not just a medical problem related to poor diet and lack of exercise, but as a social justice problem tied to stress, poverty, violence, and limited access to healthy and affordable foods. The campaign is called The Bigger Picture, and it teaches these young teenage artists, they have their projects all integrated with school systems, that diabetes is not just a consequence of an individual lifestyle choices, but a broader dysfunctional system that constrains and shapes behavior, that forces and reduces costs of foods that would be healthy, that incentivizes marketing to people of color, that allocate physical activity opportunities, that perpetuate poverty and stress, all in ways that disproportionately focus diabetes risk within already vulnerable populations. The system then directs attention to the structural causes of the diabetes epidemic in youth, particularly people of color, and it taps into adolescents' deeply held values that social justice, resistance to manipulation, and desire to protect their families and communities, and their drive to have a voice gives them an agency in affecting change. Disability, next consider disability and the social expectations and limitations that we have around sex. When you are disabled, And I'm using that word on purpose because it's what's used in the article that he intentionally uses. The two things people think that you can't do are fight and have sex. So I've got a black belt and I'm really good at shagging. So this is multidisciplinary performer who explores the connections and performance between disability, entertainment, and sexuality. And again, I'm using disabled peoples on purpose because it's consistent with the article. Disabled peoples' sexuality has been suppressed, exploited, and at times destroyed over centuries. Images of disability and sexuality tend to be absent, where disabled people are presented as asexual or else perverse and hypersexual. Disabled people are rendered impotent and sexless by disability and seen as unattractive or vulnerable to mockery and exploitation. Again, note that disabled people is because it's used in the article that this quote is taken from. You think of then the epidemiology of how we connect social conditions to influence health. Other kinds of places that we see disparities we might think of in terms of intergroup orientation, disparities in health and illness, disparities in healthcare as they co-construct each other, and we might understand this connection between relationship characteristics as also within the social, economic, organizational, and interpersonal context, including the doctor-patient as an intergroup context and the levels of difference that we might also see as intergroup differences that then co-occur with different incomes, different education, less prestigious jobs, as also at higher risk for chronic disease, disability, and premature mortality. I'm wanting us to next consider the role of the physical body and the language that we use for illness and the way that the physical body changes in close relationships with health and illness. These images come from the Saving Faces. It's a series of paintings where it's an integration of art and medicine, where the painters come in and paint the patients before, after, and in some cases during facial surgery. And what I like about these images is it gives us this kind of sense of the way close relationship processes involve the body and the mind. Stories have how we feel in our emotional state are manifest in the physical body as an instinctive knowing, as an intimate and dynamic relationship between the feelings and the thoughts. We consider illness as inherently manifest in the body, but then we introduce some kind of aspect of the physical self that we miss in the language of diagnosis. And that's, in some sense, what the body knows, but what medicine can't name. I remember that soon after my mother died, I developed a case of frozen shoulder. It was in my left shoulder. It causes stiffness and pain in the shoulder joint, and it occurs for really seemingly no reason. My doctor told me that because my shoulder was frozen, there must be adhesions or scar tissue that were freezing up the shoulder joint. And probably my body lacked something, some kind of fluid needed to lubricate the shoulder joint. I asked him what causes this, and he couldn't say because medicine doesn't really understand why it happens. But what he could do is just refer me to physical therapy. I like to understand why things happen, and sometimes medicine can't just tell us that. When we have some kind of sense of what is going on in the body, it also gives us a sense of bodily doubt, where the embodied experience of illness makes us break down the expectations for normalcy of being able to go through a day and not being able to really trust that the body is able to feel the senses that we have in being able to walk through a flight of stairs without questioning or we're going to lose our balance, or it's different from questioning things like tripping or feeling exhausted at the end of the work. It's a fundamental doubt in being able to trust the body. Illness is also manifest in this body where we didn't realize how transparent the body was until we experienced symptoms in the body, and then the body becomes the carrier of these kinds of experiences so that it no longer is transparent, and it poses all kinds of questions of what the ongoing meaning of the body is. Time and that's the meaning. The experience of living in the body as a characteristic of the human experience that's shifted both in close relationships and sometimes being able to not name and sometimes being able to name, but in not trusting the physical sense. This body disruption can just inherently change the tacit sense of being able to trust in one's own body. as well as being able to trust in the time and space of illness. Illness as this embodied experience is manifest in how time and space change. In health, clock time is scheduled and predictable. It's scheduled around what we want to do with our lives. It's scheduled around what's predictable in the rhythms over the course of the day, when we know we do better in the morning or when we do better in the evening. In carrying out medical routines instead, we can involve this need for accurately attending to clock time. Things become before and after diagnosis. Things become before and after treatment. Things become around the next appointment. Things become extra time invested in necessary activities that now cut into the leisure time. The space is also changed in a way that in health, space is not bound, but in illness, we can no longer move through space in the ways that we used to be able to take things for granted. Sitting up can be a chore. Reaching out to reach something can feel like a major accomplishment. Objects need now to be within reach, need to be strategically placed so that the person can sit or hold an object with assistance as they move through a room. The body can feel fundamentally alien. It can feel like this is not my body. This body is even less me. A sense of body alienation where we don't really understand the self anymore as in our bodies. In explicating illness as embodiment and considering this holistic view of embodiment, we gain a different sense of the concept of what bodily doubt is, a different kind of estrangement and attachment, a differentiation between the self and the body. In everyday interaction, you might just think about how the backless gowns translate into this. In harder interactions, we might think of the physical and cognitive effort for just dealing with illness and surgeries and the physical consequences that give way to the dualism then between the body and the self. In relationship research and in communication research, we have a couple of different ways we think of relationship theories as applied to illness transitions. And what I'm going to do on these is just give you a really brief overview, because in our world, these are the things you already know how to most easily find. And what I'm trying to do instead is some more play around things that may not have been already, connected in these kinds of ways. Relationship theories as applied to illness transitions, we might think about dilemmas, about when to share, about how to share information about illness, dilemmas about whether we'd want to go on a date with a chronically ill person, about whether the complications of the chronic illness might just be too much, about when we disclose private information, about relational instability or turbulent erupting, because the process of navigating relationships now involves a different kind of uncertainty and vulnerability. Interdependence, and if you play with just some of the disclosure dilemmas as they fit the ways we think of these questions, you might think about like the sharing of being HIV positive in dating, having a number of different people to date, but at what point do you share the question? And three theories that you might look at for where you can already find the information, and if you want like a summary of the stuff that's already been done with these theories, you might look at interdependence theory, where we're co-creating behavioral and cognitive understanding as shaped by another person, a cornerstone of our relational processes. I'm happy to share the summaries of these if you're wanting like already done summaries of these. Another one is relational turbulence theory, where you think of relationship qualities that are exacerbating the experience of the negative emotions that might promote negative cognitions and might then be complicated between parties. Relational turbulence is then manifest in more frequent conflict, more frequent and intense emotions, and heightened relationship thinking. Communication privacy management theory would look at how do we change the rules and the context around who knows what and with whom the information is shared, and how different kinds of diagnoses can shift the rules for that. And then what I'm wanting to think of is what's missed in the ways that we traditionally think of theory. We think of theory as that how it is applied and how do the rules change, and that's really, really helpful. But I'm wanting us to then go back to the reason we started with this broader sense. How do we actually do code generative processes between all that occurs in health and illness and all that continues to emerge in health and illness in close relationships. The end goal it changed me. What I actually thought I was going to end up doing when I did this was interconnecting, like we see, different kinds of models of how to think of different kind of constructs. And instead, I ended up leaving with this really this really broad base that I think I'll never go backwards from, of the idea of things having to be inherently co-created, co-generative, and systematic. These stories that I shared at the beginning about my mom and Tim, as well as the stories that we share in our own sense-making, give us some sense of the complexities. But if you think of those as then having to be co-created not just with the person, but within the relational constructs, and within the health and illness trajectories, it gives us a sense of the way we can listen to the process of the body and the meaning making, and also the new self and the relationship to the body as it changes with illness. Sometimes these changes are carefully measured and medicated, as is the case with my mom's Parkinson's, that you wouldn't really need to know. She's done a really good job of setting up the whole house so that she can go through and have what she needs always there. Sometimes these changes might be some really deeply internal knowing in the ways that Tim may or may not have known that something was going on with his body. I especially liked the image of engaged theorizing as a good conversation or a close friendship that lets us find something within ourselves that is there but that is not yet manifest. Where we put the inherent knowledge at risk in being able to see the different kinds of vulnerabilities instead of just applying the theories and looking at how the theory then changes. A recent conversation I had with my mom, one of the things I'd shared with my sister, is that I had some concerns about my mom going into a place that you have to go in healthy and then is continuing care. And one of my concerns about that is that she was moving into it in Georgia where my stepfather lives. And I had clearly mistaken. My sister had said, "What are your thoughts on this?" So I shared my thoughts. And I very clearly mistaken that my end goal was really I wasn't supposed to have shared my thoughts. I was really just supposed to provide support, right? These places of enactment that what I wish I'd done is first gone and been with my mom in the interaction instead of, she'd shared the interaction, so there was some damage control when my daughter and I showed up. Flannery O'Connor talks about in literature that literature wouldn't be possible in a determined world. Flannery O'Connor also talks about not being able to know thoughts until I see them written. We might even think about that, and it's one of the things we find in our having doctors keep journals. We videotape a lot of interactions, and then we have doctors keep journals about what they see in the interactions. And one of the things that we keep finding as a pattern is that sometimes people don't know even how they feel about the interaction until they see their writing about the feelings. Do we know how we feel about that? It's consistent with some of the literature that we have in the field. I like the idea really of the mirror and mirror image, where if you put two mirrors together, you see ongoing images of one and the next and the next and the next as this, what do we think of as systematic and co-generative. A systematic understanding really means that the process is generative. The process itself can recognize the way that the tensions, the dualities between the close relationship processes and health and illness are generative in and of itself, instead of just continuing to connect different kinds of models. We also think of in this way, thinking of co-created, where it's not just understanding what we do know and how to better understand what we do know with tighter diagnosis, but we can also see what do we not know yet. Co-created theory then engages the complexities of the part of the subject matter that continues to evolve and change within us, subject matter of both close relationships and health and illness, but where it still has some kind of mystery, where we can engage the mystery, the unfolding, the parts of the subject matter that we do not yet know, the part of the selves we do not know, the parts of the relationships we do not yet know. How then this emergence is sometimes manifest in the body and sometimes manifest in new aspects of the relationships. One of the things that one of my favorite co-authors talks about is that one of the outcomes of, she has this shoulder pain that's made her no longer able to practice medicine. She's like, what I've really realized in this is how much my spouse loves me. And she's like, that's actually been a very different outcome than I ever would have anticipated. We also might think of the manifestation of the multiple lenses as the nonverbal context existing alongside what we think of are more tightly illustrated verbal things set up. This is one that kept me from ever thinking that I liked systems before. This is first acknowledging this change of feeling states. This is the complexities with an academic complex systems perspective. My friends asked my kids at some point in this writing, what is your mom's favorite book? And they're like, well, I think it is this book called Handbook of Systems and Complexity in Healthcare. And it's this model, and I've heard this guy speak several times because he's around Boston, and basically they put together a conference, but it's what I always thought that complexity would look like. There's so much going on here that I think, oh heck, there's all kinds of stuff, and the book is a great start, but I feel a little like this place of oh heck. And then one of the places I found in the book that I did love is distinguishing complexity study and theory of how things are connected as two different kinds of ways. And one is the Albert Einstein quote, that the world will not evolve past its current state by using the same thinking that we had that created it. The way we theorize and the way we talk about the world is some way of being in the world. The behavior of complex systems components allows the context to vary and to be cogenerative with the context. This image helps us illustrate complex but not necessarily adaptive systems. In the Handbook of Systems and Complexity, they have this really nice image of distinguishing between two ways of doing systems and complexity, and they talk about the first group coming with an understanding and talent and high-level math to offer possibilities of really high-level mathematical modeling of chaos and complexity. That's the one that I will leave to them to do. And then the second group is motivated by understanding chaos and complexity as a metaphor to make sense of the experience of caring for patients, to reunite the complexities that we used to polarize as the distinctions between art and medicine. And that is the one that instead of going from the version that might need more mathematical modeling, we then recognize productive tensions in the ongoing understanding between close relationships and health as an ongoing productive tension. Recognizing this possibilities then lets us see the multiple lenses to continue to emerge, sometimes in context, sometimes in relationships, sometimes in finding new parts of the body. It then becomes where communication can act as the emergent property in which the close relationship, someone tries to articulate the aches and pains, and in feeling too tired to engage, and the close friend or relationship partner's words or nonverbal context or expression of empathy or understanding and or resistance or confusion or commitment to conquering the systems become very different things in their communicative action. So 3 images that give me also a sense of how these fit together. These are 3 images all from Naples, Florida, which is one of my favorite places that I've always spent time after time with my mom at the beach. This is what what we think of as we're on break. Systematic understanding then is the same peer, right? Where communicative processes here have these clinical encounters that don't just focus on the patient or clinician, but co-emerge. Openness then to the emergence requires a capacity for patterns that can't be predicted. And they certainly can't be predicted by more tightly scripting, as we see, for example, in electronic health records, tightly scripting in all the relationship kinds of questions, right? It requires a way of thinking of design so that we can see how this peer and this storm, or this piece we would call storm, or the surfer, might indicate some kind of non-linearity in the interaction continuing to wrestle with the understanding and the ongoing decision-making so that the decisions that we make carry with us the context of the past, but also the emergence and responsiveness that can be manifest in language. They're sometimes really subtle. They certainly are not done better with tighter questions. One of the things that we find is, like we've done on electronic medical records. We've tightened in the way that we ask the question, where the understanding might actually be so subtle, as one of Tim's ongoing questions was, when he would say, tell me how you really feel about that. What I really knew is, right, you get it. You don't need to understand any part of the way that I go through the world, but you're able to just hear the tell me how you really feel about that. And it was a teasing me about it. Then we see this kind of non-linearity. A key property of systematic processes is that this non-linearity allows for the kind of co-emergence in understanding, the co-emergence in decision-making, and in connecting the trajectories with the close relationship processes. If we think of emergence in close relationships, then we're attending to the generative processes, and we're able to attend to the relating and also the potential dynamic new ways of being in close relationships. This is the book cover, and this was a student who was in my interpersonal class last spring, who, when I said, can you bring somebody that you have a close but kind of complicated relationship with, in 10 minutes they sat right down here, and you could tell they immediately were diving into, all these kinds of things of past history, and you can fill in whatever the context is, but that it captures both the closeness and some form of turbulence. It means that the logistical and the clinical variables don't ever completely define the boundaries of this fully co-generative system of what the potential is that's outside of the close illness. So with that, I'm closing with some form of the book cover on health and illness and close relationships. This project where the writing has certainly changed my way of thinking, from interconnecting different kinds of theorizing to how are things generative. In the How Are Things Generative, we do have this new place that's the Institute for Communication and Family Medicine. The co-director of that is this guy who created one of the systems in the, I'll call it in the past, in the kind of recent past, that he's looking for something of how does it go forward, and created systems of what is evidence-based medicine. How does evidence-based medicine, with the best predictable evidence and being able to not be the expert in all of the evidence, fit with close relational processes? And what we're trying to do then is have ongoing reflections and videotapes of the encounters be a learning system that incorporates the set of family medicine physicians that we have. That's like 300 in the New England area.
So we'll do Q&A.
So it seems to me, as you're thinking about trying to think of health differently,
Yeah.
as other people are,
Yeah.
and even that is, once you start to go in there, you just realize how impossible that is almost. But it opens up all kinds of new things to think about, and it seems like you were bringing some. You wanted to look at that the kind of interplay between health. As defined in illness and relational processes. But it sounds like in learning more about health from doing that, you also learned a lot more about relational processes. So what are some of the things that, if you're teaching interpersonal rather than one that's tied to health specifically, how is it changing some of the ways that you're talking about
Interpersonal?
I mean, some of them are obvious, but in some really fundamental ways, how did it also change?
How I talk about interpersonal?
Yeah.
Oh, I love that question. One of the things that I find is I find myself saying, okay, so I have to do this with you, and here's how we go, and here's what Theory X says. But actually, I would say that here's the cognitive answer to how we recognize feelings as the cognitive feelings and feeling response as the cognitive explanation for needs not being met. And I would say one of the things about then recognizing, the co-construction of that is that when things are sometimes even when they are what we expect, when we leave the space for things to continue to emerge, we can find things within ourselves that we didn't know how we feel, and that then sometimes the finding language for gives us, at one sense, an ongoing capacity to articulate better emotional complexities, that it's not just a feeling, but I'm feeling, jealousy as combined of these different kinds of pieces, and I both am worried about losing you, and I can't imagine actually having take the kids to school every single day by myself at the same time, right? I want to be these dual pieces of both and. Yeah, it's let me play with this piece of, in mindfulness and in those kinds of languages where we talk about, the state being something that we can notice and then move past. It's made me adopt far more noticing and then can you move past, and are you ever finished noticing? Yeah?
Makes a lot of sense too. The whole thing about expectations too, I found really interesting, and the story, the narrative that we tell ourselves about what our own lives are going to be like, or what our relational lives are going to be like. And it doesn't even have to be through illness, but the same things that you apply here, that there are going to be these things that break the expectations. Mm-hmm. And being able to talk about that more with kids, especially in college, before they're on the biggest arcs of their relational lives, to understand that that's normal, whether it's going to be a transgression, or whether it's going to be illness, or whether it's going to be a job change, or poverty, or something else like that. Upheaval is going to happen.
Mm-hmm. And when I play with what's different in illness, it has all those same kind of vulnerabilities that are similar to change in college and all these kinds of choices. And the difference in illness is that we don't anticipate it.
The other thing's the same, though. I mean, that's what it made me realize is that when you were describing that, there are
it feels exactly the same.
Not exactly the same because of the body aspect, and because of some of the uncertainty around it. But I think that can be. There's a lot of things that just sort of drop. Mm-hmm. One day it just drops, and we didn't see it coming. And it may have something to do with the other person, or it may be something that's coming from the outside. But I think that's the norm that we don't necessarily talk about. I mean, I know with relational turbulence, there is some of that conversation. But that the norm shouldn't be this arc, that we're going to expect this particular trajectory. We should sort of expect this and talk about relationships like this. So it gave me a lot to think about.
Thank you.
Yeah. Can you maybe talk about some of the opportunities and challenges of co-generation, co-construction around invisible illness?
Yeah. So that one, right? Pain, right? Pain is such an example. And I also think, in one of the questions I always look at is, your stuff about the invisibility of not knowing family relationships, right? It's something that unless you tell someone, but when you tell someone, then they still have a boundaried context within which they think they have some meaning of that, right? Some of the same kinds of, it's a great example of same kinds of parallel processes, right? Where even telling you more words around the vulnerabilities of that reconnection, right? So invisible illness is one of those things where, like pain, right? There's no objectivity around a pain scale. And there's all kinds of writing around the pain scale as an illustration of the best we have is my comparison of language of experience today with my comparison of language of experience with tomorrow, and the gentleness or the subtleties of the co-construction might be manifest in when I start to share something with you about the intensity of the pain, and I experience even a shift in topic or a shift in something that feels invalidating, I might share less and be able to do less with you about that experience of pain, right? Where when I see some kind of piece that might be far more manifest in the subtleties of what's going on in your facial response, I then feel differently able to dive into and understand with more complexities the experience of a physical sense of pain, right? Which might be far similar to what I've read about your pieces of what does it mean to reconstruct the relationship when you come back into a family.
Yeah, I just think that when you invite other people into that process, if they don't have language for it, right? Just have you read the Elaine Scary stuff? Right? When you don't have language to talk about it, how many obstacles that creates in that co-construction process, even though you're already co-constructing because you're together. Yeah.
Not having language for it is something that we already have in our language for how to be in communication scholarship. Being able to be with and co-construct understanding is the piece that might be the experience that's not yet recognized, right? The nice friendship where the being with someone in hard times in silence means we don't have to give this such words, or at least we might not have to give it words that feel complete or finished at this time. Yeah.
I'm invested in, as you showed the image of the book cover. But, oh, that's really interesting that these are young adults. Their relationship, I'm not sure what their relationship is as opposed to some of the other images. Like, well, that's obviously
Right.
mother and daughter. That's
Right.
obviously people in a romantic relationship. But I am curious about how this manifests differently in different types of close relationships. Romantic relationships versus parent-child versus siblings versus close friends. In most of what you said, even though the examples were varied, it seemed like those were just collapsed into close relationships, but I'm assuming there must be some differences there.
So I was trying to play with all kinds of things. I was trying to first take out parent-child or doctor-patient or things that are non-reciprocal, right? So and then assume that you're able to keep renegotiating within the piece of what is closeness, right? Okay. Parent-child's differently tricky, right? I'm always going to be, revert back to some part of me that is the part that is in Georgia, that is in rural Georgia when I'm back in that relationship with my mom, because the parts that are, far hardcore, the academic parts, these all kinds of pieces that don't fit do you see what I mean? Mm-hmm. Those pieces that are different than reciprocal, mm-hmm. right? They're the kinds of ways that different than reciprocal is manifest. One thing about illness that is different from other kinds of close relationship processes is the substitutability function, right? You really can have, and I really am I'm in some ways like far more comfortable in a place, in something I can have a kind of tumultuous relationship with someone at my university, but when they have a heart attack, they know that I am more comfortable in the hospital than I am in my department, and that is a really comfortable space, and I can sit there for a couple days at a time and do the closeness and vulnerability that the heart attack involves, because on some level it's a constrained context of all of those pieces. Several times that who becomes your person that sits with you in healthcare, that people talk about things like my spouse, I can't go with her. I can't actually see her being that. So I have tried, it was an intentional decision of kind of collapsing those, but I also get the difficulty of that. And in some relationships, the need to have been, there through the parts that were that kind of vulnerable are really important in how people do that relationship.
Or I also imagine that the shared knowledge, for example, I have a friend that also had breast cancer. I'd love for her to be my support in these particular ways, would trump other types of relationships for particular kinds of needs.
Yeah. And I look at, I have this group of women that they seem particularly close. They're really just neighborhood people that when you look at them, you wonder, why are they so close? And then I know the backstory, that I know that they actually kind of got to be that close because one had breast cancer, and over the course of the group, 6 have had breast cancer, right? And that is a different place where even though on the surface all we're really doing is sharing, are you going to the 9 o'clock class or the 10 o'clock class, right? The piece of they have been the ones driving each other to those appointments and sitting with each other, and all of the relational stuff that unfolded because all this messy stuff was going on in different parts of people's lives during the course of the time.
exist, right? Like people couldn't get those needs met with their typical close relationships, so they go to the support group.
Maybe, and I would say both ends. So maybe we aren't getting those needs met, so we go to the support group. Or the support group gives us some context for sometimes how people are sense-making around something that is new for us, right? The support group may or may not then go a direction that feels different than my choices or my next piece of something unfolding.
Yeah, it's really interesting. Yeah.
The unfolding as a life-giving, kind of flourishing unfolding, even if it's not easy.
Yeah, okay, that makes a little bit more sense than thinking through. Like, it's a great for theorizing, too. That you're like, all right, well, this is about reciprocity and close relationships, so the closeness is defined in a particular way.
Yeah.
This is how that unfolds. It's kind of nice versus this is how it works with partners.
Yeah. No, I would say it probably is not how it works with partners and probably is not how it works with, right? And what we know, you talk about families. Families are certainly not always close. Families are all kinds of things that might be close because they're all kinds of things that the substitutability in health is about the place that has a need to be met. But certainly, families are another example of we have these expectations where the expectation of first the end goal would be treatment. Maybe the end goal is actually, one of the things I know my mom does not want is to actually ever know she has a diagnosis. She wants never to be tested and measured for anything ever again. And she will never, I hope you're never watching this, bud. They're just not on the same page about that and haven't been for the last more than 10 years. And so it's something in their relationship, you agree, we'll just never talk about this anymore, right? And on some level, my ability to not live there and know that that's the answer means I can carry the hit, so to speak, for whatever those decisions are around something that's inherently complicated because I can. And my sister, for example, she needs that relationship to be always supportive for her because she sees it as, I do love him, I care for him much, but she sees it as the father figure who needs to always be, filling some pieces of father figure pieces that she just needs to always be, more warm than I have a need for. If I can find the warmth from, it's not that he's not warm, but I'm totally not happy to. Happy is just the closest language we have for. I am totally willing to be the one making hard decisions for people in several of my women's groups of close relationships. Because then I go home and the spouse hasn't been the one who had to do the hard thing.
That idea of sort of focus on quality rather than type of relationship just made me think about a number of things. And you were talking about the example that you were talking about parent-child, and I assumed you were going to talk about you as a parent if you were parent of a child, but you were talking about you as a child parent of a parent, which made me think that there is a sort of interesting reciprocity, not in all families, not in all relationships, but assuming that they stay intact in some way. As the child is growing, very unequal, the parent does much more for the child, but there is a sort of expectation that at some point the child is going to do much more caring for the parent. Mm-hmm. And so sort of this lifetime, you have the whole lifetime, but it's actually still going to be a relatively equal relationship in terms of caring if you look across the entire lifespan. Mm-hmm. And I had never thought about it that way. And I was also thinking about sort of the support group thing. I think that some people like the support group because it gives them a chance to talk about things with other people who are going through it. Everyone is getting to talk and everyone's getting to listen, so very equal. Mm-hmm. But when you are in an illness situation and you feel like you're being over-benefited or you're asking for, you need a whole lot more at that time and the other person has to give a whole lot more. I think sometimes we want to move into a space where we don't feel that inequality. Mm-hmm. So we like the support group because we're not asking for our friends and our family and our partners to do even more by listening to us or to help problem solve with us too. Mm-hmm. So those concepts of equality and reciprocity as qualities in relationships make it much more theoretically and practically rich than what is it like in parent-child or what is it like in husband-wife, spouse. Interesting.
Did you have a question?
Yeah, first a comment is thank you. This is an important conversation that you're bringing forward for us. And I'm just curious because I work in the healthcare system, and I'm just wondering what your experience was like as you got to know the providers and healthcare professionals to take on this work of bringing interpersonal communication into a healthcare setting and collecting the data you needed. And just curious, because their mindset is quite different than one of a communication scholar.
And remember, I'm also in Boston, where it's like healthcare mecca. And boy, has it been a steep learning curve on so many levels. Sorry, did you finish your question?
Yeah, I just want to hear your take on what hurdles or successes you had as you navigated those relationships through your work.
A couple things. I was telling some of your grad students at first, coming from the University of California system, where when you go in, you're part of the University of California system, or I'm part of the University of Washington system, where you carry some kind of cachet with you, some kind of trust is probably the more, we trust you because you're part of the system, is not the case in Boston. Because in Boston, there are already 6 med schools, and I'm not one of them. And all of the hospitals are already affiliated with the med schools, and I'm not one of them. So the steep learning curve part of feeling like I was cold calling on selling myself was a really steep learning curve. And what I really like to do and find helpful is to bring audio recorders and video recorders and do both the scientific modeling behind the sets of a zillion nonverbal behaviors and qualities of the face and the voice and the body, as also connected to the transcripts. And one of the things I very quickly learned that was really important to me was that there was, and cogenerativity is now the word I would have for it, but people are sharing things with me that are never going to be my story to tell. So I found very quickly that I never would move forward with anything without always returning to the people with whom I'd shared a set of experiences to make sure that everything that I was doing in describing their sets of experiences felt really resonant with their world. So I spent a lot of time sharing, in these early days, a lot of it was with the disability advocacy community. I would always present the work first to them and hear their responses. So it really felt like developing relationships with the people was part of the, not just trust building in order to accomplish a goal, but a building relationship trust in that the way of asking questions about the stories was not my coming in with answers or best practices, but an inherent place that was recognizing what they were sharing with me as their own life. Does that make sense?
Absolutely.
It feels, it's just extraordinarily humbling to be able to have the organizational support for being able to now come into anything and have it be that people sit down and talk about the complications that we sit down with the patients and talk about things that they wish to have happen. I sit down with the doctors and talk about things that they wish to have happen. I regularly go in with doctors and some kind of thing that they know something's going on, but they don't know what. And we talk about what that might be, and we might audio record it, and we might transcribe it, but they're often complex problems, kind of questions that just don't have easy answers. And I've come to actually at least think of, if not appreciate differently, the need for that kind of collaboration as really important to who I am in my work, always. Yeah. Which is, of course, a very different answer than I would have had when my question would have been, but I need to, how can I have access to, in order to, and my IRB deadline is due, and my whatever other kind of thing is due. Yeah, so now I find myself inviting a lot in, and when their question is, they go to something that's always complicated, and they come back and they're like, I just can't actually, these are stories of people who I would call refugees, but they don't even have state status, and this feels ethically something that's complicated. I'm like, then you can be part of the team. Because I'm needing, the wrestling with piece is really important, right? It really is important. Yeah.
I was curious what difference it makes whether the illness is endogenous or exogenous to the relationship.
That's a great question.
Because it seemed like there were a couple of examples where both were either one was present, so either Parkinson's sort of happens upon a relationship in this outside of the system manner, or frozen shoulder as a result of a change in a relationship.
It's a great question, and it's a great question that you get back into all that kind of stuff of what's the definition and how do we define it. So we think of, for example, relationally prompted, and I'll call them relationally prompted instead of relationally based, and I'll say we think of them as relationally prompted. Things like, maybe you might call the frozen shoulder if I attribute it to it being connected to when my mother died, or maybe I might talk about depression as inherent to, a timing, these kinds of things. But when you look at the questions, we think of then outside of the self cancer, for example. But when we look into what that actually means, a disproportionate amount of cancers are also connected to all kinds of lifestyle questions and or economic questions and or environmental pollution questions, right? It becomes quickly not quite so either or. When we make attributions for it in the relationship, then we use language to more bring it into the relationship, and is that a truth or is that the current experience? Does that answer with a yeah.
Quick question about Cambridge and
Sure.
and the idea of closeness and your thoughts on, do sites like Cambridge, what the influence they have on how either we feel a close sense of closeness to the patient? Have there been studies that have looked at that in the thinking way that I'm just curious your thoughts on it. Did you have examples?
Yeah, no, I pulled that example actually because of all kinds of things that I don't know. I don't know the absolute answer. I don't know the answer to what are the studies on Caringbridge. I pulled that because one of the things that I was finding in that friend of mine is that the shift to then things needing to be always showing the closeness aspect and the we will get through this aspect just felt like it was capturing something that again was, the gentle turbulence of something that is
The observation of the dynamic that was happening and
Yeah.
unfolding on Cambridge.
Yeah.
Because I'm also interested in the dynamic of how we as support networks that may have various different relationships with the person who is ill,
Yeah.
how Caringbridge facilitates us either feeling closer, maybe it's over geography or it's somebody we knew 25 years ago, but now they're in our inbox all the time because they post a lot, and just the experience of illness
from a distance.
From a distance.
It's a great question.
So,
From a distance is one of the aspects of it, right? Is totally, this woman that I was very close to in Santa Barbara during my PhD program, who all kinds of traumas that you look at, wow, like if I didn't know that story on Caringbridge, I would only know the outcome. Right?
so you get this whole narrative.
You get the whole narrative.
Go on for years and years, and so the Caringbridge is a site that is not only for them to communicate with you, but suddenly you're part of this larger conversation. You're connected to people because they're building in these social dynamics to Caringbridge, so that you're able to see each other's comments and then say, oh, well, that was a friend from high school, or oh, and I haven't talked to them in 20 years. I mean, it's just fascinating.
But it's not co-constructed, right? Caringbridge, if you're looking at the questions, I always wonder, at what point does it then, there's so many different ways of framing the story, and one of the ways on Caringbridge of framing the story is the closeness and how we are coping, the communal coping kind of story with the closeness. I do not know of stories well enough there of, are you unpacking all the things that are falling apart in the home life on Caringbridge?
I'm curious, I have an example where, I know we're hitting 5 o'clock, but that both the husband and the wife were posting, so then it does become more a conversation, and then the husband continues to post after the death of the wife. So it's not even just one voice that's coming through Caring Bridge, but it can be multiple people can host.
And Caring Bridge is one aspect of it. And I think of also like in communities, when my son was very young, there was a boy in his grade who had brain cancer, and his mom was also going through cancer treatment. And one of the, ongoing stories in the community was the mom and the son were going through different kinds of progressive treatments together, and the community aspects of how are those stories co-created. Yeah.
So thanks very much for your maybe think about it in different ways.
Sure.
With that, we're almost time, and so let's once again thank Ashley Duggan.
Thank you.